Thank you, John and Kat and the whole committee for inviting me down to Florida. I got to tell you, I am so grateful to be here this time of year, especially from New York, as you heard, and it's 30 degrees and ice storms every other day. And I had to make a pit stop in Michigan to see my son on the way down here. That was 17 degrees. And college kids, they don't have a car, so you just walk around everywhere for days. So I am thawing out, and I am really, really, truly grateful. So what I'm trying to cover in the next hour before lunch is the following. I want to give to you a highlight, in my opinion, of some of the mental health challenges of our youth in the 21st century with a little extra emphasis on the impact of technology. I want to present to you what DBT for suicidal multi-problem adolescents looks like in both clinical settings and school settings. I want to give you a little bit of the data from some of the randomized trials that have happened with that population. And you know what a bluff is? The bottom line up front. The bottom line up front is that DBT is to date the only well-established evidence-based treatment for suicidal multi-problem adolescents in outpatient settings. If we come up with something that's better, I will come and teach you that. But that's what I know to be the one treatment right now. So just when we think about our youth and what some of the kids are dealing with, you know, day to day, excuse me, there is so much, and you've heard from this morning's amazing presenters, there's so many different adverse events that they're dealing with. But some of the other ones, in addition to, I think we have, you know, racism and promoting social justice, but that's an ongoing challenge. We have school shootings at Robb Elementary School. We've had in the past year, if anyone's noticed, some political divisiveness that has happened. We've had world wars happening in Ukraine and Russia, and of course in the Middle East going on as well. And then just a couple of weeks ago in New Orleans, we had some in-state terrorism happening right down on Bourbon Street. And so if you're a kid and you have access to the news, which now everyone does, which I didn't really have that level of access when I was their ages, it is a constant barrage of frightening images and challenges that they're facing day to day. And it feels like it's right in your backyard. And some of the things are in their backyards, but some of the things are around the world, but it just feels like there's frightening images everywhere. So already at baseline, they're already emotionally vulnerable just walking around day to day. As you heard, Ernestine was talking about the Surgeon General, Vivek Murthy, talking about in the last several years, we are in a mental health crisis. And everyone in this room is well aware of that. That is not a newsflash. But what are some of the factors that I think are influencing mental health for adolescents? I've already alluded to some perceived and real dangers: school shootings, community violence, racism, anti-Semitism, Islamophobia, homophobia, transphobia. We could just go on with the list of phobias and isms that are plentiful and real for our young people. Terrorism and wars. But then you throw in, I think, an interesting piece of this for the I generation, right? The I generation are people born with smartphones in their hand and internet access at an early age. And the paradox of this social media connectivity, as we'll talk about a little bit more, is lower social support, greater loneliness, depression, self-harm, and I'll go into some of that in more depth. There's also rising pressures of branding yourself in these colleges these days, right? Who are you? And I was just visiting my son. I mean, it is unbelievable. In high school, you have to have your brand to try to apply to college and have this established to be competitive. And this idea of careerism, when you're 17, 18, 19 years of age, you got to know what you're doing. And it feels unduly anxiety-provoking to the point where kids in college are much more anxious and depressed these days than they were 20 years ago. There's also this notion of a lack of mattering, not who you are, but what you do, what you are. Are you a teacher? Are you a plumber? Are you a lawyer? But not, who are you? Well, I'm interested in, I'm like going on hikes where there's snakes. I like, I like doing things. Yeah, just not that part. But I like going, but you know what I mean? Who are you? Not just what you do. And that is inadvertently invalidating of a young person who were less focused on their interests and what makes them happy and what their pursuits are outside of their career trajectory. And as I'm going to talk about, Jonathan Haidt's work on overprotection and underprotection. So let me talk about this work. Has anyone seen or read his work yet? Because I really want to encourage you to take a good look at this one. This is worthy of some diving in on this book. He talks about this idea of these two trends of overprotection in the real world and underprotection in the virtual world. And he thinks that these are the reasons why so many of our kids born after 1995, meaning the I generation, became the anxious generation. Now, here's the thing. That equipment on the top right was what I played on when I was a young boy in the 1970s. I'm not even kidding. Like, that was my gear. Like, that was my jam. And why was that so much fun? And I'm a little older than the average age here. But for those of you who did do it or can imagine doing it, what is the joy of that old rusty merry-go-round? What is it? So, you can fly off of it. That's the joy, right? And no, but all kidding aside, there's risk involved. There's a chance of some minor physical harm. But that's not bad. That's not a bad thing. Developmentally, we need to test the limits when we're growing up, right? That's a challenge for us. But what happened was people get sued, people get injured, and we became a litigious society. And then what came in the 90s, in 2000s, is that sanitized playground that my children played on. It was uber safe. Nobody gets hurt. Nobody has fun. But it's safe. And at the same time this was happening, by the way, in between my playground and my children's playground was the birth of video games, and kids were now in their basements playing video games, also safe and sound, because then there was all these controversies with the Boy Scouts and the churches and the sexual abuse scandals. It's dangerous out there. So in between these years of my youth, there was increasing worries and communications of danger and trying to keep everybody safe at home. Now, this is relevant because of this idea of we became a much more overprotective society. And just as a brief aside, I wanted to reference Michelle Borba's work. In a related vein, a corollary to what I'm saying is this idea of not only overprotecting, but overhelping. You guys know what I'm talking about with this idea of overhelping parenting style, where you're always swooping in and trying to solve and problem solve and rescue and do all these things for kids. Isn't that so loving? It's just so sweet of us to do, except for one thing. We're not teaching our kids how to make their own mistakes, how to learn from those mistakes, how to deal with frustration and disappointment. And so the problem with this overhelping idea is that we reinforce the idea they can't do it on their own, and so we'll take care of it for them. And how many of you have seen, or even yourselves maybe done, let me help you get that, for 18, 20-year-old, let me help you with your letter and get that out for that job interview, or let me do this or that. And it's not to say you can't give help, but I've seen families doing it, parents doing it for the kid. The kid didn't even know the job application went out in the mail or the email. So there's, in some communities, not all communities, there's this overhelping idea. And when I was in Norway a few years back, and I was talking about this American parental phenomena in some parts of the United States, they were laughing out loud Norwegian laughter, but it was still laughing nevertheless. And they said, that's parental curling. That is what they call it, where you know that Olympic sport where you send that silver disc and then there's adults, who are sweeping and sweeping and sweeping to let the silver disc land perfectly. That's the idea, where sometimes we swoop in and do too much. And that's just an interesting aside, but I think the research is interesting. Correlationally, we're having a lot more kids failing to launch. We're all helpful in their teen years, but then they try to send them off to college or vocational school, and so many of these young people are struggling with greater rates in young adulthood of anxiety and depression and self-harm, and I would argue dependency. I don't know how to do these things. I don't know what to do to help myself and deal with this disappointment and frustration. So just going back to Jonathan Haidt's work for a minute, the underprotection side of the coin is that he thinks we haven't protected our kids from this phone-based childhood. And he says there's 4 characteristics that I want you to keep in mind, which I think are relevant treatment targets for our therapeutic interventions. One is attentional fragmentation. Sorry, I just got a text, 1 second. That is, how often do you talk to somebody and their head goes down? So attentional fragmentation. Addiction, if we're going to be so bold as to call it that. Social deprivation. I'm really good with this, but I'm not so good with this. And sleep deprivation. So I want to go over these 4 quickly with you because, again, therapeutically and in DBT, as we'll talk about this, these are some of the targets that we're keeping in mind when we work with our kids. But just look at the attentional fragmentation for a minute. When you add it all up, the average number of notifications on a young person's phone from social and communication apps is 192 notifications per day. That's 11 per waking hour. So how many do you have students who are in school with their phones? And so they're looking at their teacher and they're getting 11 or 12 notifications per hour while they're learning. Okay. That's for heavier users and older teen girls especially, that's 1 notification per minute. Those are some interesting data to keep in mind when we're thinking about how to regulate cell phone usage in schools. And Jonathan Haidt's recommendation, and I agree, is do we really need to have them have their phones throughout the day? Could there be breaks at lunch or whatever, but do we need to have them have it in class? I would say I would vote for no. And some places in New York State, for example, are starting to implement that in other parts of the country as well. Now, just coming back to Vivek Murthy for a second, he was trying to get Congress recently to put a health warning label on these platforms, basically saying that when a young person spends more than 3 hours on these apps during the day, doubles the risk of anxiety and depression. The average daily use of this is about nearly 5 hours a day. So it's correlational data, but it's still quite concerning in terms of how much risk there is, seemingly, for higher rates of anxiety and depression. Now, some patients I work with and families say my kid is addicted to screens, addicted to their phone. And the smartphone is the modern day hypodermic needle delivering digital dopamine 24/7 for a wired generation. How's that for a quote? That gets your attention. Jonathan Haidt's work. That's his quote. So again, it's so insidious. It's so insidious. I had an adult patient who's 30 years old, 35 years old, has 2 young children at home. And she was telling me that she's doom scrolling, she said to me the other day, constantly scrolling anytime she has a break. And she's a tutor, academic tutor. She's also starting a small business. But anytime there's a break, she's scrolling. My own son, who I feel is generally speaking well-adjusted, said to me a couple of months ago that he and a bunch of his friends decided they're taking off TikTok, Snapchat, and Instagram and leaving it on their laptops, but so they don't have the constant addictive, any moment in an elevator, at a urinal, at a whatever, you are just doing this, right? Any moment. It's unbelievable. And he said, it's a game changer, Dad. I'm feeling so much kind of cleaner and clearer in my mindset. So I was telling my patient, essentially what my son was recommending, and it's having a real effect on him, and I was encouraging her to try to do the same. So where we can moderate use, let's not kid ourselves. We're not getting rid of these phones and these apps. We're not getting rid of them, but can we moderate use? And I know some of you in the audience may be thinking about this for yourselves as well. Now let me just turn to problem number 3, which is the social deprivation piece. So Jean Twenge, some of you know her, is a psychologist from San Diego State University, and she wrote the book called The iGen, and that came out about 10 years ago. And then she published another book called Generations. And she's looked at large swaths of adolescent populations over the last 40, 50 years. And what she has found is, and I don't know why I'm looking at my slide, it's cut off on the bottom so you can't see chronologically, but it looks like around 2007 is when the iPhone came out. So trust me, this graph goes up around 2007 and basically saying, around that time, many more kids, 8th, 10th, and 12th graders, felt left out and lonely, all right, around that time. Again, this is correlational data. It's not causal, but I just wanted to show you this. Around the same time, 2007, 8, 10, 12th graders not satisfied with themselves and not satisfied with their lives as a whole. Again, I'm sorry why this is cut off here, but same thing in terms of more 8th, 10th, and 12th graders experiencing depressive symptoms. And Jean Twenge said, well, is it possible that unemployment was the causal factor for some of this? And maybe that's why kids got more depressed, young people. But you can see that faint white light line that's going down to the right there is unemployment. So unemployment was coming down, but still internet use, depression, social media, smartphone ownership, all going up since around 2007, if you can see that. Now, interestingly, coming back to this overprotection idea, kids with their smartphones, with their video games, in the basement, with IV drips so they don't have to step away, they had less alcohol use, less driver's license, less work for pay, less dating, less sex from the 1970s and 80s till today. This is the trend line, if you can see that. So our kids are not exploring in adolescence. They're not going out and doing what is more traditional adolescent behavior. Okay? So again, I'm not rushing them to do all those things, but it is interesting to see how much they are not engaging with other people and doing what were traditionally more adolescent young adult activities. But one of the most disturbing stats is this one. And again, if you can see this, and this goes up more around 2010, 2011, but sleep is problematic. Do you have young people who you work with that are getting less than 7 hours sleep on average? Okay. Many of you have that. You know what the American Pediatric Association and all the other organizations that work with young people, the recommendations are what? How many hours? 8 or 9 hours for adolescents. I work with patients who are saying they get 4 or 5 hours. It's often interrupted. They're going to sleep with this device on their chest, right, in case, they also double as mobile crisis team operators. You know this. So they can't be, in case someone needs them, they have to have access, right? So this is what you need to know, right? So they have to be available, and also their boyfriends, girlfriends, whomever want to fall asleep with each other that way. And so, but all kidding aside, this is a really serious problem. I did a study with some of my colleagues at Montefiore years ago. About 10 years ago, I think we published this article. And what we found was that the kids who had trouble falling asleep, staying asleep, or waking up early, so that's kind of, initial insomnia, middle insomnia, terminal insomnia, also had higher rates of self-harm, ideation, self-harm behavior, and suicidal ideation as well. What do I mean by that? I mean, not only did kids have trouble with attention, we knew this already. Kids had trouble when they have sleep impairment with attention, more rates of anxiety, higher rates of depression, greater risk for bipolar episodes when you have sleep impairment, right? We knew that. But I hadn't known with adolescents that you could have higher rates of self-harm and suicidal behavior when you have sleep impairment. So that got our attention. Houston, we have a serious problem with sleep. And when as John was mentioning, at Montefiore Medical Center, I spent 20 years in the Bronx at the Albert Einstein College of Medicine running an outpatient clinic for suicidal, depressed, kids with trauma, anxiety, eating disorders, substance use. I mean, we had a litany of disorders and difficulties and stuff in the community, a lot of community violence. And problem number 37 was sleep problems. We'll get to that later, I used to say. We'll get to that later. We'll get it. But then we did this study, and this was a wake-up call for me and my colleagues, and we decided, you know what, we have to target and treat sleep problems more aggressively. I know Cindy was talking about this, and I know everyone's talking about sleep, right? So we decided to add to our, something's going on with my slides, but sleep has already been part of what we call the emotion regulation skills, ABC, please. We have a lot of acronyms in DBT. And sleep, S in please, is balancing sleep. The L in please, it got dislocated, basically is limiting screen time to less than 3 hours a day is the other addition to our please skills for those of you who are familiar with DBT. But we basically said, okay, if we're going to treat sleep, we got to treat it aggressively. And so we added a whole sleep hygiene protocol in our emotion regulation skills in DBT. It's 12 tips for better sleep. This is not rocket science, ladies and gentlemen. These are tried and true good sleep hygiene methods that other people have established that I encourage you to think about. And when you go over this with your young people, you'll be shocked how much they need help in this area. Now, does this treat insomnia as a protocol? No, but it's useful to help reduce their vulnerabilities to insomnia. So I would encourage you to assess how is your young person's, your students' sleep hygiene doing? Okay? Tell me when can I go? I see some, no, did you get it? Did you get the photo? Okay, good. No, oh, you're social, okay, good, okay, all good. Now, here's another thing. I'm not sure what's happening with my slides, but that red box is not supposed to encircle medications. It's supposed to circle sleep, and it got on the right next to meds, which you can't see, is what time are they going to bed and what time are they waking up? Okay, and so what I'm trying to say to you is I am now tracking their young person's sleep. In addition to many other things we're tracking in terms of treatment targets, every patient I work with now, I am looking at their sleep. What time are you going to bed? What time are you getting up? Now, do I know whether they have interrupted sleep and they're on their phone at 3 a.m.? Not necessarily from this, but I will assess that further. So I want to encourage you to take sleep seriously. So Andrew Solomon, who's studied a lot on suicide, written a lot about suicide, just came out recently in the New Yorker magazine, has social media fueled a teen suicide crisis. And he says, among his young survivors of suicide attempts that he interviewed, few mentioned social media as a factor. They pointed to a sense of impotence and purposelessness, climate change, the brutal language of modern politics, intolerance for their gender, race, or sexuality, bleak financial prospects and something. Let me see if I can move this. Oh boy, okay. I don't know, guys, I'm really sorry about the slides here. And social mobility, and an inability ever to feel that they had caught up, as though their brains were slower than their lives, which I do think is part of the high-tech world we live in, coupled with acute loneliness, even among those who appeared not to be lonely. I thought that was an interesting perspective. And he cited also Lawrence Steinberg, some of you know, as a well-respected researcher and professor, and has outlined 3 potential causative scenarios on this topic. Social media causing mental disturbance leading people to overuse social media, or some unrelated issues boosting both mental disturbance and social media use. All of these interpretations are reasonable. So I think we all want to hop on the bandwagon, and I've certainly been passionate about my concerns about social media, and I don't want to throw the baby out with the bathwater either. I mean, if the truth be told, right, the YouTube is the most used by young people. YouTube, more than even TikTok, for example. And YouTube teaches you things. YouTube is useful sometimes. So I don't want to throw the baby out with the bathwater and say we can't do any of this now and have the pendulum swing the other way. I just want to figure out a moderation approach to doing this and have a reasonable conversation about this. Now, as an adolescent suicidologist, as John mentioned, I ran this adolescent depression and suicide program at Montefiore. And in 1995, there were 30,000 Americans dying by suicide every year. 30,000. And now, fast forward, 27 years later, this is data from 2022, about 50,000 Americans dying by suicide. So we're definitely not going in the right direction. So that's about 1 suicide every 11 minutes, right? So by the time I started this presentation, and by the time I finish an hour later, we'll have lost at least 5 or 6 more Americans dying by suicide during my presentation time. So those are the numbers. And like COVID, all these numbers, you can get a little bleary-eyed. You get desensitized. Well, I remember, in New York, it was New Rochelle. Case number 1, ground zero. Everyone knew about that guy. We knew his whereabouts. We knew exactly what happened. And then 2 people got sick. And then we knew about those. Then it was 10. Oh, my God, 10 people. And in the same vein, after you get thousands and hundreds of thousands of people, if we're being honest, we get a little desensitized. And I feel like even around suicide, we can get desensitized by these numbers. But I can't let that happen, nor can you. So just to tell you in context, my grandfather died by suicide when my dad was 17 years of age. He worked at a department store in Manhattan. He got laid off. I have a feeling he had some underlying predisposing mental health disorder, like probably a depression or something. And he sadly, hanged himself in the family home basement. My grandfather and my father had to find him. So you can imagine that effect on my dad. He was the oldest of 3 kids, had to be elevated to man of the house at a young age, trying to help out in that regard, if you will, working and this and that and contributing. My grandmother was working, of course, too. No, not of course, but was working. But this was my family legacy. I had one of my beloved psychology interns who graduated and years later had young children, went back to her apartment in Manhattan on the 27th floor and decided to take her own life and jumped off the balcony and died by suicide. Postpartum depression, insufficiently treated. And then a few weeks after that, a young man, incredible basketball player in my neighboring town, who I'd just seen watch him play at the Westchester County Convention Center. He was having lunch with his dad. His dad left his service revolver on the coffee table. And the dad went out to get some lunch. And this young man took his own life with that service revolver. So all 3 human beings, special people, lovely people, and suffering people. And to me, 1 suicide is too many. We have to work on preventing this. And the more we understand, there's a lot of risk factors, and there are protective factors, and there are treatments that now work. but we have to do better to let people know how we assess for it and how we refer people to get the right help when they need it. Because I cannot accept 50,000 plus. And by the way, that number is an underestimate because there's so many people who are, being labeled as accidents and so on. So that number is way, way higher than that, okay? So when I'm working with you guys today, I'm asking how many kids and teens in your neck of the woods have engaged in suicidal behavior and non-suicidal self-injurious behavior. Raise your hand if you know a student or a patient, a young person who is engaged in suicidal behavior and non-suicidal behavior. Okay, so that's most of you. So even if you choose not to make this your career trajectory and say, I want to do DBT and I want to work with suicidal people, this is everyone's problem and we have to figure out how to do better. Because the facts of the matter are, more than 1 out of 5 adolescents in high school around the country has seriously considered suicide in the past year, okay? And by the way, during the pandemic, it was 1 out of 3 girls who seriously considered suicide in the past year. Unbelievable number. 1 out of 6 made a suicidal plan, 1 out of 10 actually attempted suicide, and about a third of them, 1 out of 33, made an attempt that required medical attention. So that's suicide. But then we have non-suicidal self-injurious behavior, which to me is the coping strategy of the 21st century of our young people. Sadly, right? It's the deliberate direct destruction or alteration of body tissue without conscious suicidal intent, but resulting in injuries severe enough for tissue damage to occur. So what kind of methods do your kids use to self-harm? Cutting, burning, reopening up scabs and wounds, punching oneself, banging oneself. So, these numbers are even higher, right? So large numbers of young people in community settings are engaging in NSSI, depending on your sample. It can be anywhere from 14 to 30%. College kids, sometimes even higher rates in some studies. So it is a real problem, which to me says, I don't know how to cope with my distress. I don't know how to manage my emotions and distress, so I'm going to use this, unfortunately, as a maladaptive coping strategy, which tells us we need to teach young people more effective coping skills, period, end of story. If that's what you're going to go to, you're going to cope with your impulses and your shame or sadness to cut yourself. You've learned that. Oh, it's 5 minutes already? Oh my goodness. Okay, I better move. Then that is, we start at 11:15. So is that really it? I just need a few more minutes. Okay. I'm begging for time. All right. So let me move it on then. I'm getting a little carried away. The problem with applying standard treatments to multi-diagnostic, difficult-to-treat patients, Marsha Linehan, who is the mother of DBT, noticed when she applied straight cognitive behavioral therapy to her adults who had at the time suicidal behavior, multiple diagnoses and problems, straight CBT did not seem to work. And those patients that she worked with seemed to feel, Dr. Linehan, you don't get it. I can't just change. I have a drug addiction problem. My kids are in child protective services. You can't just tell me, do this, change your behavior, think this way. You don't get it. And they felt like she was just so change-oriented, so focused on the change that she didn't communicate an understanding of their pain and how difficult change was. And so they got more dysregulated in the process. Because if you ever felt invalidated, you would get emotionally dysregulated too, by either saying you don't get it and getting emotionally outbursts, or withdrawing and shutting down and dropping out of treatment. So you said, okay, that's not working. Let me try plan B, which is let me focus on accepting the patients and how they're doing in the moment. Life is hard. Change is difficult. I get it. This isn't easy. And at first, they're like, oh, it's great. You understand my pain, Dr. Linehan. Thank you so much. I really feel like you're getting me. It is so hard, so difficult. Oh, my goodness. I don't know how you're making it through. All right, it's great you understand my pain, but now what am I supposed to do with it? I need some tools, for crying out loud. You can't just keep telling me you get it. I mean, so that support was nice. And that was when she said, okay, this is the birth of dialectical behavior therapy, where she was balancing the change strategies of CBT with more of the acceptance strategies of what she did with mindfulness, meditation, and her Zen practice, which she now converted into behavioral skills, and balancing change and acceptance, where you're now doing a dance between communicating to your client and patient, you're doing the best you can in this moment, acceptance, and you need to do better, try harder, and be more motivated to change at the same time. Now, how can you be doing the best you can and need to do better? That's complicated. But think about that. If you can embody that as a clinician, as a teacher, where you're letting the student know you're doing the best you can in this moment, and you know that they haven't slept, you know they have a family situation that is really straining them, you know they have a math learning problem, right? So you know they have a lot going on, and you want to validate that, but you don't be like, all right, well, I get it, period, I get it, and what can we do to help you learn this subject? What can we do to help you with X, Y, and Z to do something differently than what you've been doing? So validation and change. And it sounds so obvious to anyone in this room, like, well, isn't that what everyone does? Well, not exactly. Not exactly. And Marsha Linehan really made this more transparent and explicit as for clinicians who are working with this population, that you have to balance that more. And so when we talk about dialectics, you can be both doing the best you can and need to do better. I can be deadly serious about teaching DBT to you and still joke around and be playful. I can say that I love this device because it has my music, my photos, and my communication access to my kids and my friends. I love that. And what? And it drives me crazy. It's intrusive. It makes me anxious, right? So both are true. Both are true. Many of our emotionally dysregulated young people get polarized in very extreme ways of thinking. I'm either stupid or I'm smart. I'm either fat or I'm skinny. I'm either lovable or I'm totally unlovable. And how do we help our young people think and act more dialectically? And if we had more time, I'd have you, in your spare time, I want you to think about a dialectic about yourself and a dialectic about the world around you. Real quick, January 6th, you guys remember a few years ago? I thought to myself watching the news that day that our democracy was so fragile when I saw what happened, And then 4 hours later, I'm like, wow, democracy is also so resilient. It's both fragile and resilient. And so I want us to adopt this dialectical way of thinking about things and help us find a synthesis. It can be both this and that. I can be both serious and silly. It's not either this or that. Does that make sense? So about 30 years ago, my colleague Jill Rathis and I, along with Marsha Linehan, adapted her adult work for adolescents, Black, Hispanic youth in the Bronx, where we worked. And it has now become, like I said, an evidence-based treatment for suicidal multi-problem youth. On the left is the textbook that we use for really a treatment manual for individual therapy. And on the right is the skills manual we use for teaching skills to teens and families in usually group settings and typically multi-family group settings. And I'll talk about that. But here are the 5 problem areas, and it kind of maps on a little bit to Jonathan Haidt's problem areas, right? Attentional fragmentation, I said a few minutes ago. How many of your young people have trouble staying focused? They're looking at their teacher and their mind wanders backwards to what they feel sad about or forward about what they're anxious about, and it's hard to bring their camera lens back. Even right now, some of you might be looking there or even looking at me, and it's possible you might be thinking, what's for lunch? It's possible you're like, something's on your mind about your family. And I'm not judging it. I'm just saying, can you notice your mind wander and can you gently bring it back? That's the skill called mindfulness skills. And for kids who are constantly distracted, have attention spans less than a goldfish, 7 seconds, they need to build their mindfulness muscles to be able to stay focused and read something and listen to somebody that goes on for more than 7 seconds. And you can teach this through what's called mindfulness skills. For kids who have emotional dysregulation, which is fast, intense mood changes with little control, or a steady negative emotional state, we're going to teach them a whole host of emotion regulation skills. Helping kids identify and label emotions. How do you teach them how to reduce their vulnerability to negative emotions? And that's where that sleep comes in, how they balance their eating and other things. And if you ask one of your kids, how do you increase positive emotions? I don't know. They say, I don't know. I'm going to teach you ways of increasing positive emotions and emotion regulation skills. So there's a whole host of skills for distress tolerance skills that map on to helping impulsive kids and those who have addictions, including addictions or self-harm, right? Distress, how do I cope with my distress and not engage in the urge? It is a game changer for so many kids. Interpersonal effectiveness skills to help them with their interpersonal problems. That loneliness I was talking about, that social deprivation, they have atrophied or never even learned how to make a conversation, how to make a friend, how to get what they want effectively from people, how to keep their self-respect. So those are interpersonal effectiveness skills. And then Jill Rathis and I added this 5th module called Walking the Middle Path Skills because we wanted to formally teach teens and their parents how to think and act more dialectically, like I just said a moment ago, how to increase validation towards other people, like literally let other person know, I know you guys have been sitting here for 3 hours. It is late in the morning. Technically, like we're going past the time because, no, it's okay, but I'm saying, but I'm aware that some of you may have phone calls to make because you told people that there was going to be a break at noon and now you're still here. Like, that is hard. I am letting you know I get it. I get it, guys. I get it. But I mean, I'm sincere about this. Like, how do we teach people how to validate not just about lateness to lunch behavior, but other things that are happening? And sometimes we as caregivers and parents lean in, and I'll talk about this in the workshop this afternoon, with this reassurance. Don't worry, it's going to be fine. It's okay. You're the best. You got this. And we are not truly validating, I understand you're really worried about how you're going to perform on your exam. Worried what's going to happen when you go to this friend's house tonight and you feel like people are not going to give you the time of day. I hear you. I hear you. Before we rush in with, but have you tried this? Can you do this? Right? We're so quick. We're good. We're good at giving suggestions and problem solving. It's really good. It's just premature. It's premature. So we got to lean in with some more validation. So I want to teach the teens and parents I work with how to do that, as well as principles of reinforcement. What is positive reinforcement? What's extinction? What's effective punishment? So there's a whole body of skills in walking the middle path skills. So why DBT for adolescents, real quick? The data we think is compelling now that we have 3 randomized trials on this population. The biosocial theory, which I'll teach this afternoon in the workshop, is how do kids get to be emotionally dysregulated? And why do they stay emotionally dysregulated, many of them? Well, there's a theory that has the biological basis to it and a social basis to it, which I'll explain later. I love DBT personally because it's skills-based, and as somebody who likes to just teach and give skills to people, I love the opportunity to have them see this, not that they're unmotivated or they don't care, but they have a skills deficit. And some of us are more skilled than others. Some of us have a natural jump shot, can play piano by ear, and others have to work harder. And we're going to get some of these kids who have some of these skills deficits to learn it, strengthen it, generalize it, work harder. And we're going to get them those skills. And it's a multimodal intervention, which I also enjoy because you work once a week individual sessions, once a week skills class with teens and parents, coaching during the day. So if was going to say if the shit hits the fan, but I guess I just said that. But if something happens at 11 or 10 o'clock at night and they're like, I'm having urges to hurt myself or engage in suicidal behavior, they can call me for coaching before they engage in the problem behavior. Now, some of you are like, oh, I like what he was saying until that moment. I don't know if I want to do the after hours piece, but to me, it's a privilege to be able, for those occasions when they're having the urge, I'd much rather hear from the 15-year-old at 9 or 10 o'clock at night than hear from the ER first thing in the morning, I got your patient. So that's a value proposition that I ask you to consider. And the last modality I want to mention, in addition to some family sessions as needed and parenting sessions as needed, is called the DBT Therapist Consultation Meeting. And this is a team meeting to support one another in the work that we do, because working with multi-problem suicidal youth can be burnout inducing if you're not careful. And we want to make sure that we attend to our colleagues' emotions, our colleagues' burnout, and validate them and reinforce them and make sure we're all taking care of each other. So let me just say, because how many minutes do I really have? 1 minute? Okay. All right. So, oh yeah, time for questions too, yeah. So there's been 3 randomized trials, and one of the ones, the first one that was done in Norway, comparing DBT to enhanced usual care. The kids who got DBT in a 19-week randomized controlled trial had significantly stronger reductions in self-harm, suicidal ideation, interviewer-rated depressive symptoms, hopelessness, and borderline symptoms after 19 weeks. And at 1 year and at 3 year, we have those follow-ups. We were able to keep the self-harm significantly lower than the control condition. The 10-year follow-up with Lars Mellem, who's the primary investigator from Norway, is coming out soon. So we'll have the 10-year data, which is, I got to say, kind of exciting to have 10-year data on a randomized trial. All right, so I clearly didn't time this well. Let me just say one last thing. One last thing. We saw a pyramid earlier. I think Cindy showed this of different tiers. In schools, you guys know we've been adapting DBT for school settings. And tier 1 is a universal population. Tier 2 is selected, our target, and tier 3 is intensive. And we have 2 types of DBT in schools. Universal classroom, where teachers take that curriculum I just showed you and give it in classroom settings. And then for some kids, the smaller group of kids who are multi-problem and already self-harming and impulsive or substance using, et cetera, we give comprehensive DBT in schools. And the 2 manuals we give, there's one called DBT Skills in Schools, and there's the other one we use for comprehensive DBT. And so I think you should hopefully have these references in your slides, right, Kat? Yeah. And there's some data on schools too, which I'm telling you exists. And we also have Spanish-speaking versions of those manuals as well, in case you want to have a Spanish version. So let me just say, even though I presented a lot of things that are upsetting to you, I am actually feeling hopeful that we have, a lot of our colleagues you've already heard this morning, and more evidence-based treatments are coming out to help these multi-problem populations. And I wanted to just tell you that I think we're making some progress incrementally. And thanks to you and learning it and getting better at it, we will hopefully change lives and save lives. So thank you for your time today. Thank you. So we have one or 2 questions, and then we'll go for lunch, guys. Anybody have a question? Yeah, in the back.
Hi, thank you again for this. This was really informative and helpful. I guess I've used DBT. It's been a lot of fun, and I've seen a lot of success with it. I'm thinking in the context of working in an inpatient setting and the nature of the hospital and the healthcare system. Tops, let's say, best case scenario, maybe I get 48 hours, 72 hours with these patients while they're there.
Yeah.
So it's not ideal, especially when we're looking at it from a life skill or a weekly skills basics and being able to set that foundation. I guess from your perspective with that context, best case scenario, what should we what can I do in the short amount of time I have with these who are the most severe populations?
Yeah, good question. First of all, there's a couple of references I can send you to in terms of Larry Lawrence Cates, or Katz, K-A-T-Z, but he pronounces it Cates. He's from Canada. He did an inpatient adaptation that I'm also on from years ago, applying DBT for inpatient adolescents. Well, that was about 10 days, and now I know we're down to 2. The outpatient target hierarchy, reducing life-threatening behavior, reducing therapy-interfering behavior, reducing quality of life, all that stuff is out the window. And what you need to do on inpatient is, number one, reduce egregious behaviors that got them hospitalized in the first place, and any other life-threatening behavior. And all the other stuff, you just leave for outpatient work. So it's what got them in, chain analysis, and in my mind, try to do a little bit of validation with the family, mindfulness and distress tolerance. That's it in the couple of days you have. So it is harder. Yeah. There's no magic bullet. I haven't seen data on 3 days or 2 days, so I can't say that works. But if I had to cultivate a program in 48 hours, really kind of biosocial theory to explain to the parents how the kids got this way and their role in some of the transactional nature of invalidation can be powerful.
Do you think there's a difference between, just as a follow-up, the individual portion versus when they're doing it in a group setting in this 48, 72-hour window?
I think there's value of having kids with other kids, seeing that they're not alone, and learning some skills together in the couple of days you have, because you have now more than 1 hour, 2 hours. You got couple of groups over a couple of days, and yeah. But I would put them in a group as where I can, plus individual, plus family. That's all. Yeah. Yeah.
More complicated than that. Thank you. Appreciate it.
To your right.
Oh, yeah. Hi.
Well, thank you so much for your words. I felt like I gained a lot of wisdom. I have trouble whenever knowledge is presented, the application is somewhat more convoluted, right? So when we're working with these youth, so I'm in a community mental health setting, the reception isn't always as easy, right?
Yeah.
So what language could we use to encourage the reception of what could possibly save their lives?
Oh, that's a good question and not an easy answer. I do think you're right. You have to get creative. You have to build rapport. You have to get them to trust you before you start throwing, oh, this is a good manual. You got to learn this. You got to learn these skills, right? You got to get to know them. And some of what we heard this morning in terms of who are they, their identity, all their strengths. Like I didn't have time to get into some of that, but I want to focus on their strengths, not just their problems, and really amplify that. And so I'm going to spend, rapport building and kind of what I call pre-treatment, if you will, before we then get them to say, okay, I'm ready to start working on some of this stuff and do skills training and all that. So it's a process, and that could take 3, 4, 5, 6 weeks, and sometimes longer before I would ever put somebody in a skills class with their parents. Because if they can't say, I want help with this, I don't want to throw it. To your point, it's going to be a waste of time, right? So, but use yourself, be your engaging self, use some self-disclosure where relevant in terms of, as a therapist, in terms of as a skills trainer, how I have coped with things that have been difficult and use skills and they've helped me. Because, a lot of these kids are looking up to you guys, right? And where you can be a model of coping, not a model of mastery, not like, I got all this, I got no problem, right? I am coping using some of these skills myself.
All right, let's thank Dr. Miller.
Thank you. Thank you, guys. Thank you.